When a clinician performs a standard perpendicular intramuscular injection, they create a direct, linear channel. The needle passes straight through the epidermis, down through the subcutaneous fat, and into the deep muscle. Skeletal muscle tissue exists under resting internal pressure. Once the fluid is deposited and the needle is removed, this internal pressure actively compresses the muscle fibers, forcing the deposited fluid back up the path of least resistance. This retrograde flow is irritating. When viscous or highly irritating solutions track back up the puncture channel, they enter the sensitive subcutaneous fat, becoming the primary cause of severe localized tissue morbidity. To counter these exact fluid dynamics, clinical practice relies on a specific mechanical engineering solution, the Z-track technique. By design, the Z-track technique creates a physical, mechanical seal to trap medication within the extravascular muscle compartment. This mechanical intervention is a clinical mandate for agents defined by 3 specific pharmacological profiles. First, pigmented agents. Second, caustic solutions, and viscous formulations. Examining the Z-track protocol reveals it is a study in fluid dynamics and anatomical engineering, built to counter the biological pressures inherent to the injection site. The chemical properties of a specific medication, its osmolarity, pH, and vehicle, dictate the absolute necessity of the Z-track. The first risk category involves pigmented agents, most commonly iron dextran supplements. If iron carbohydrate complexes leak into the subcutaneous layer, they absorb poorly and cause permanent brown-black skin discoloration, known in clinical literature as tattooing. The second category includes caustic solutions, such as the antipsychotic haloperidol or antibiotics like ceftriaxone, which possess highly irritating pH levels. Subcutaneous fat is densely packed with sensory nerve endings. Exposing this tissue to caustic agents triggers intense pain and often leads to the formation of localized sterile abscesses. The final category comprises viscous and oil-based formulations, like testosterone or hormonal slow-release treatments, which naturally resist rapid tissue absorption. Pushing an oily bolus into muscle creates high internal pressure. This resistance makes these thick formulations uniquely prone to tracking back through the needle channel. To see why this tracking is so damaging, look at this fluid dynamics model comparing the 2 anatomical environments. On the left, the subcutaneous fat has a sparse capillary network, causing thick oils to sit stagnantly. On the right, the deep muscle tissue features a dense, fast-moving vascular network that allows the same oil to rapidly diffuse. The pharmacological success of these specialized drugs relies on completely bypassing that subcutaneous layer to prevent systemic treatment failure. The Z-track relies on subcutaneous elasticity. Initially, skin, fat, and muscle sit vertically aligned. The clinician pulls the layers laterally, shifting them out of alignment. Maintaining traction, the needle passes at a 90-degree angle, piercing these displaced layers to reach the target depth. Once the plunger is fully depressed, there is a mandatory dwell time. The needle must remain in place for exactly 10 seconds to allow the initial fluid bolus to disperse into the surrounding muscle fibers. The critical biomechanical shift occurs during the release phase. The clinician withdraws the needle while simultaneously releasing the traction from their non-dominant hand. The natural elasticity of the displaced fascia causes it to instantly bounce back to its original resting position. This rapid elastic return pulls the entry, midpoint, and exit layers of the needle track entirely out of alignment. The linear channel is broken into a blocked, jagged Z-step pattern. This zigzag deformation creates a perfect mechanical occlusion. The overlapping tissue layers form an impenetrable physical barrier, locking the medication depot deep within the muscular compartment. Incorrect anatomical landmarking during a Z-track injection carries the critical and often avoidable risk of severe neurovascular complications. The most serious complication is direct injury to major nerves, such as the sciatic nerve in the gluteal region or the radial nerve in the deltoid, which can result in temporary neuropathy or permanent paralysis. These direct needle injuries to nerve pathways range from reversible conduction blocks, known as first-degree injuries, to severe Wallerian degeneration, where the nerve fiber degrades entirely. Furthermore, incorrect depth, hitting blood vessels, or failing to rotate injection sites can lead to localized bleeding, hematoma formation, and tissue fibrosis. Improper technique can also trigger Nicolau syndrome, a rare but severe condition of ischemic tissue necrosis caused by accidental injection in or around an artery. Hitting the correct muscular depth is the primary way to prevent this outcome. This fibrosis creates unabsorbed medication deposits, ultimately reducing the desired pharmacological effect and compromising patient recovery. Even a successful Z-track seal cannot prevent injury if the anatomical landmarks are identified incorrectly. Precise mapping is the clinician's primary defense against catastrophic outcomes. To mitigate these neurovascular risks, modern clinical consensus has narrowed the acceptable anatomical targets. For adult patients, the ventrogluteal site is the universally preferred location for all intramuscular Z-track injections. The geometry of the ventrogluteal site provides a highly protective, thick layer of muscle mass covered by a very thin layer of subcutaneous fat, ensuring the needle safely reaches the correct depth. Adopting these evidence-based standards requires examining historical nursing dogma. For instance, as highlighted in this literature review, the practice of aspiration for blood return was largely added to nursing practice based on anecdote, assumption, and arbitrary choice. Current data shows that while aspiration is entirely unnecessary for standard immunizations, it remains a debated precaution when injecting thick depot medications like penicillin. But while aspiration is debated, the necessity of the Z-track technique is not. The clinical evidence consistently proves it prevents sterile abscesses, tissue necrosis, and medication leakage. Continuing to rely on outdated linear injection methods carries a heavy cost, extending patient recovery times and burdening the healthcare system with preventable complications. Ultimately, clinical excellence stems from the seamless integration of pharmacological theory, precise biomechanical execution, and uncompromising anatomical accuracy.